The mic? I think I'm too short. Oh, it's too high for me? Okay. All right, is that much better? All right, so before I jump right into my presentation, I'd like to share a story with you. So the image you're seeing is of a friend of mine, and her name is Mutinta. So about 2 months ago, Mutinta was a regular 4-year-old. She lives in a township called Mutendere. If you're not familiar with Lusaka, Mutendere is a big township which is right behind the hospital that I work, Levi Mwanawasa University Teaching Hospital. So one day, as Mutinta was playing with her friends, she knocked over a bucket of hot water which was on a brazier, and she got burnt. And as you can see, this was quite traumatic for her and her friends. Luckily enough for Mutinta, her mother was close by, and she came by to administer what she thought would help her child to survive. And as you can see, that is Mutinta and her mother administering some first aid. I'm sure you are wondering how this story of a small girl is research. Well, at that moment, what my friend Mutinta does not understand and her family is that everything they do, the clock is ticking, and anywhere they go will determine if she can survive from that burn injury. My topic today is on assessment of acute burn care at pre-hospital and tertiary hospital, and this was a retrospective cross-sectional study. So this study is part of much bigger work that we're doing under a grant through the Royal Society. And one of our study sites had no information on what the current state of burn care was, so that is why we undertook this study. So what is acute burn care? So acute burn care includes all interventions that are made from the time the burn injury occurs to about 2 weeks when the wound starts to heal. If done well, acute burn care has the chance to reduce both the depth, progression, and ultimately the outcome of the burn wound and the patient. It includes things such as home first aid, like pouring cool water for scalds, removing clothes that have been burned, isolating the victim from the electrical source. At the hospital, acute burn care includes all the things we do, like fluid resuscitation, wound care, assessing for life-threatening injuries, and also for burns in special areas. So we conducted a retrospective study, and we were able to identify patients that had a diagnosis of burns in our hospital register, and this was from 2018 to about 9th July this year. And the register we're talking about is for one hospital, which is Levi Mwanawasa University Teaching Hospital. Essentially, this is the second largest hospital in Zambia. We collected data on demographics, cause of burn, percentage, time to presentation. We were also able to determine how far the patients traveled from the referring clinic to our hospital using Google Maps. We read the referral notes to look at what the clinics did and looked at the admission notes, and if the admitting doctor asked about home first aid, we took note of that. We also looked at what was done in the first 48 hours. So at the time we submitted the abstract, we had identified 124 files, but because we were crunched for time, we couldn't include the other files we later identified. Our final paper, once we publish, is going to have about 250 records that we found. And as you can see, over 50% of the patients in this hospital were male, under the age of 5, and most of their burns were caused by hot water. Also, on the other side, you can see a pie chart, and you can see essentially that the burns that we're treating at that one center, majority of them, 75%, are less than 20%. The median distance traveled from referring clinics to our hospital was about 8.35, but this was a range between 2.6 to 155 kilometers. The average time to presentation for those patients that managed to reach the facility in one day was about 5.5 hours, and in the late group, this was almost 7 days. So what was striking is that we can see that 84% of the patients managed to reach both the clinic and the tertiary hospital within 24 hours. As you can see, there's still a photo of Mutinta and her mother administering some first aid. Mutinta's community essentially has access to some clean water. As you can see, there's a bucket of water by the side, which seems not to play a role in her community. So when we looked at what the communities did when burns first occurred, you can see that 51% of them would apply eggs to the wound, 22% would apply the cool water, and then all the other substances were added as first aid. Well, at the local clinic, as you can see, because 90% of the patients we receive at the tertiary hospital all pass through clinics like this, but once they get to those centers, 40% get no treatment at all, and they get referred to you. The 60% that actually do get something will get something like ATT in about 6%, IV and oral antibiotics in about 30%, topical antibiotics in about 18%, analgesia in 53%, and some IV fluids in about 22%. What about at the big hospital? So what you're seeing there is an aerial photo of Levi Mwanawasa Hospital, and that's the new wing. So at the tertiary hospital, like at the clinic, 98% didn't indicate what method was used to assess the burn. 23% did have a sketch of how the burns were distributed. 84% got IV fluids, of which 50% was Ringer's lactate. 70% had analgesia on their chart, compared to 96% of IV antibiotics. Overall mortality at this hospital is about 22% in burns patients. To conclude, our study has been able to show that knowledge on burn first aid in communities is lacking. Secondly, clinics are also lacking the basic principles of basic burn management when a referral is planned, as you could see in the things that they were administering. Developing countries normally have simple protocols for small centers, which normally would include things like some IV fluids and pain, keeping the patient warm and referring, and those things should not delay the patient from being transferred. We also see that at the tertiary hospital from preventable causes. As you can see in that photo, in our files, I know many of you will read of stories where people leave braziers in their houses, and that leads to fire and serious injuries that are difficult to come back from. On the other side, we also see that as Zambia and Africa, our mechanisms of burn injury are different because of the other challenges we face. Whereas, as you can see, the mosquito net protects us from malaria. On the other hand, there's also a rise in burns from those nets being touched. And so our biggest investment in this whole burn saga is actually prevention. These were the co-authors for this paper, and those are my references. And interestingly, we're also presenting a poster on stories in burn care, where you're able to see a vision of what burn care might look like in Zambia if specialized, and also listen to stories from your patients and health workers taking care of burn patients. Thank you. Burn care is delivered in general surgical units, and when we need specialist care like physiotherapy, nutrition, or counseling, we have to make a request for those people to come and see our patients. So ideally, burn care is a subspecialty just like urology or pediatric surgery, and should be delivered within independent multidisciplinary teams which help to address the patient needs. And the advantage of having burn teams is that it's easy to coordinate the different needs of the patients and also to coordinate costs because we understand that burn care costs a lot of money. So the aim of our study was to provide a comprehensive analysis of the state of burn care in Zambia, looking for advancements in the key areas that we know are important in burn care, like surgery, nutrition, pain management, rehabilitation, health worker training, and community prevention programs. So we undertook a scoping review utilizing the African Journals Online, Zambian Medical Journal, PubMed, University of Zambia Repository, and of note was that we chose to also use the University of Zambia Thesis Repository because we know that we can trust the quality of work that we would find in there. Essentially, it is peer-mentored work. We also looked through the reference list from the other articles we found to see if we could find more studies. We also searched for specific authors because we saw that certain people were more prominent in burns. We also did a Google search because no matter what we did, some articles only came up when we looked through all the pages on Google. So our data extraction sheet collected information on study characteristics, patient demographics, clinical costs, burn prevention, surgery, analgesia, and health worker training. So this is a sketch of how we went about looking for the articles. We started in PubMed for our other study. We had a search strategy utilizing PubMed Advanced Search and medical subject heading, and we looked through 2,500 titles. We also looked through the Zambian Medical Journal, User Thesis Repository with the keyword medical, African Journals Online, and we looked through Google, and that is how we landed to our 19 articles that are included in this review. So 19 papers were reviewed, published from 1979 to 2023, and the study types were equally distributed, as you can see. And of note is that over 60% of the studies were at the university teaching hospital. 2/3 were published by senior physicians or foreign researchers. So this is just a table showing the different types of articles that we found. Most of them were hospital-based, and most of them were all published. So the total number of burns identified by our study was 8,710. The mean age was about 7.8. Male to female ratio was 1, and mean total burn surface area was 10. The commonest cause of burns was scoring, as you can see. And we were able to calculate the infection rate across the studies that reported this. And we can see that the average was around 46.7, but this was a range of 27 to about 66.5 in burns patients. Mortality rate across the studies was about 15.4, but this was a range from 12.3 to about 19. The average length of hospital stay for studies that reported this was about 15.7, and we had 5 studies that reported on conducting surgery for burns, and these studies reported that they were repairing a high number of contractures in the burn patients. Prevention studies, this was in 2 studies. They showed that our communities had low levels of burn prevention knowledge, and there was no research on other key areas we were looking for, like nutrition, rehabilitation, and counseling for burns patients. We also went further to see what our local study has been asking of us to do when it comes to burn care, and this was divided into 4 themes. One of it was need for creating a burn center, prevention programs from 2006 study, 2011, 2013, and 2023, and also need for infection prevention protocols, health worker training. And so our study highlights that we have a high burden of burns, which result in complications, and we have limited research. Strides to improve care must focus on increasing research, funding, mentorship, and translating research into practice. We should also work on training health workers and community prevention. And our biggest motivation must be especially to translate. So after all of us present all this work, we're also going to make recommendations which will end up in journals and not on the bedside. So that should be where we should be working on doing. So these are the co-authors on this paper, and these are my references. And also, our poster again, we have something. This is on stories in Ben care. In Zambia, we can't talk about Ben care without remembering someone who was very instrumental in that field. And so we are also honoring her on our poster. Do pass through. And that's the end.
Thank you very much. We will have 3 minutes of questions or comments. Mike. Hello. Ladies and gentlemen, helping us with the mic. Prof. Boa, and then we have two gentlemen behind there.
Thank you very much, Nancy. My name is Kasondebo. I'm Professor of Urology. Thank you for a nice presentation. 2 brief questions. First of all, I think you said that Ringer's lactate is the main IV fluid used for burns resuscitation, I think 74%, if I remember correctly. My question to do with that is, in burns care, there's hyperkalemia, as we know, because of lysis of the burns from heat. So Ringer's lactate is heavily concentrated with potassium. So usually most protocols would advise either half-strength Darrows or normal saline. So I'd like your comment on that. Secondly, I think burn studies in UTH have shown that burns is one of the highest cause of mortality at the UTH. And I think previous recommendations have recommended tangential excision and early skin grafting as a way to prevent the morbidity which results in contractures. I don't know whether you were able to extract this and if you are able to give any comments on this. Thank you.
Thank you very much, Prof. The 2 gentlemen behind there.
Thank you, Dr. Kasonde, and good morning, everyone. I'm Dr. Kabongo from CIDAS. I have 3 questions. The first one is on the median distance between household and health facilities, I think, which was 8.35, but confidence interval you put 2.5 to 155, which is a bit too big. So which one is the median distance? The second question, the researchers had time to look at SOPs at facilities to refer these clients to tertiary hospitals, and what management is there? Do they have clear ways of managing those clients? Which would trigger actually my last question on 22% death rates on the first study and 15 on the last one. So which one should you get? How do you explain the gap? One is 22% and the other one is 15. Yeah, those are my questions. Thank you.
Thank you very much. Just behind you.
Good morning. Thank you for the opportunity. I'm Dr. Kadima. I'd like to ask the presenter, the term of burns is quite broad. What I wanted to see in such a study is the classification, the burns that had reached a tertiary hospital. Were they superficial? There were 3rd-degree burns. Also, I wanted if they could clarify what were the causes of those burns. Were they chemicals? Were they electrical burn or heat burn? Thank you.
Thank you very much, Dr. Nancy.
All right, I'll begin with the first question on the fluid of choice for acute burn resuscitation. So in our study, we showed that the fluid that was ordered in the majority of patients was Ringer's lactate. According to most guidelines, especially the most up-to-date, the American Burn Association, so the fluid of choice is normally Ringer's lactate because the electrolyte composition in Ringer's is almost similar to that of plasma. So that is the first fluid of choice. Most times in the absence of Ringer's, sometimes we use normal saline, but we know that the content of sodium and chloride in that is high and lands us into other complications. So half-strength Daros is normally added, especially in pediatric populations, as a source of some sugar. So normally in the pediatric would give Ringer's to keep the volume and half-strength to give some sugar. So that's what the current guidelines say. There's a lot of research going on the use of colloids, but I guess in our setting, it would be more beneficial to make sure that even the basic things, which include crystalloids, are given according to the appropriate standards. And there was also a question on excision, early excision and grafting for burns patients. So actually, that is one of the things that we want to start advocating for. So currently, there is a group at UTH called the Burn Committee. Mostly, the meetings are attended by nurses, but then at those meetings, we try to discuss the things that we know will improve outcomes. As you all know, burn patients are managed within general surgical units, which you know are overworked. Their workload is so much. If you look at their theater cases, they're so long. So getting early excision and grafting on those lists becomes a big challenge. That is why the biggest thing we want to drive towards is to have independent burn units, especially at big hospitals, because then the bread and butter of those units will be burn surgery, and it's easy for that to be done. But in the current state, the burn patient will be on a list with all the other emergent or more urgent surgical conditions that end up on those lists, and we all know that. So in terms of distance, I think we presented the median distance only because most of our patients were within at least 8 to 10 kilometers, and we had a few outliers. So using the mean would have skewed our average much higher. And what we presented in brackets was actually the range. So the patients would travel between 2.6 to about 155 kilometers to get to a tertiary hospital. Then, as regards to standard operating procedures at clinics, that's why I'm here to talk about burns, because burn care is one of those areas which has somewhat been neglected. Even in big hospitals, in my hospital, we also don't have a protocol. Most of us, we manage usually looking at other protocols, so we need to start setting those standards, starting with the big hospitals and then going to the clinics. So at the moment, there really isn't a protocol telling them what they're doing. That's why you also saw that the clinics are doing all these different things when they get burn patients. Then in terms of the death rate, so in the scoping review, we presented a rate which was around 15 to 19%, and that's across all the studies that were done. In our study, our death rate is about 22%, not so far away from what we've presented from the other summary of all the burn studies in the country. And also, this is just preliminary work. We're still yet to finalize. There's still 100 more cases that we need to add to this, and then we're going to know for sure what our mortality rate is. We're also going to include all those patients whose files we might not have seen, but we'll look through the registries because they do tell us who's alive and who died. And so then we'll have a corrected mortality rate, and we're going to discuss, once the paper is done, how that relates to the one we presented in the scoping review. And then I think the last thing was on classification of burns. So that's why, again, I am here, because what we have seen in the records we've gone through not just at one side, but our much bigger study is multi-center, and it's almost a similar thing. So we have, most of the burns are just classified by percent, but the bigger thing that we need for burns is for burns to be classified also by depth, because depth of a burn will be able to tell you whether that burn will heal or you will need to do surgery. So it's still one of those things that we'll still need to keep training and emphasizing for people to do this. So currently, most burns that we've seen, even at the 2 bigger hospitals, are classified only by percent. Thank you.
So a big hand to our young lady. But you can see that there are certain things which are a disappointment to some of us who have gone through this system. That, in 2023, we are saying there are no SOPs for burns. Prof. Boa. When these things that Kraiko was working on in the 90s, what has happened? That is very, very disappointing. And when you look at fluids, again, I think, asking the young lady what fluid should she have used. I really think that, people use whatever is available, isn't it? And we had a complaint from one patient who said, they used a suture on her which looked like, those strings used to repair shoes. And someone said, well, it was silk. But it should have been a very, very big suture, And actually, it may have come from a tire. Ladies and gentlemen, I'll ask M-Life to just give us a short clip about what they do. Again, these drug dealers have given us some money. So we need to honor our pledges to them. But we will continue with the breakout. I think the next presenter, please get ready. But in the meantime, M-Life, please, 10 minutes.
Good morning, friends. You look so beautiful from here, I must confess. And even as I was walking, I think I've seen quite a number of you walking in. You really look beautiful. The name of the presenter has now changed from Nancy to Bazias Mambo. I am the Business Development Executive Manager at Madison Health. So the name that has been called here is Madison Life, which is M-Life. But I must just make clarity that Madison Life is the company that is looking after Madison Health. So in terms of underwriting, all the insurance groups, or all the insurance products that we have are covered under Madison Life, but are being managed under Madison Health. Specifically, the medical one, where we have C4C, a product that is being sold out to ZMA. So maybe just to briefly explain to you who Madison is, we are sitting under a group of companies called Lawrence Kutwa and Associates, where we have quite a number of companies under there. I'm sure some of you might have heard of Madison General, some of you might have heard of Madison Life, some of you might have heard of Madison Finance. There's Madison Assets. We also have Madison Health and Risk Management, which is M-Health, the company where I'm coming from. Madison Health is actually in charge of all health products. I'm sure some of you have treated patients that are on schemes from Madison Health. I just wanted to clarify that so that we do not have confusion in terms of which company is what, so that we move together. So this company is actually listed on Lusaka Stock Exchange under Madison Financial Services. So for those of you that may wish to have shares, you can actually visit Luce, and then you can get your shares from there. So we're here to talk about the medical insurance. So these are some of the products that we offer. We have health insurance, a product that is underwritten by MLife, hence the name that we were called. We have inpatient, outpatient, optical. We also have dental and surgical. Then we also offer international emergency evacuation. So these are some of the products that are under insurance. And then we have medical fund management, where clients will come together, or a company will bring them funds together that is made for medical insurance or medical services for the employees. And then this is the fund that we use to pay medical bills for the people that are covered. And then we also have Madison Health Opticians. This particular site just looks at specifically the optical center. So we have outreach programs where we'll go outside and we'll follow you wherever you are. We screen you, and those of you that may need medical or spectacles will be able to distribute. And then above that, we have travel insurance. As you are flying out, please remember Madison Insurance will be able to assist you with all your travel insurance needs. So it is important also to note that it is health that is real wealth, and not the pieces of gold and silver, says Mahatma Gandhi. So it is very important as individuals to look at the health of our members, also even the family members that we are living with. It is quite important that we take care of this. So this C4C is a program that was designed by ZMA to try and see how best we can help the caregivers. Most times caregivers have been neglected, and now it was an initiative of ZMA to see how best we can help the caregivers as well in terms of medical assistance. I understand you can't prescribe medication for yourselves. So it is important that we have a scheme that will be able to assist us when need arises. So this is actually the benefit table. This is where our presentation is. For those of you that wish to register, there's a booth right outside there written mHealth. You can see us and then we can help you register. So on a monthly basis, the only amount of money that you are required to pay if you choose the silver plan is a 250 for the people that you want to cover. So we have quite a number of options, about 4. We wanted to see if we could add another option, but for now, as we are beginning, I think these 4 options will be enough. So we have silver, we have gold comprehensive, and then we also have diamond. So on a monthly basis under silver, if you contribute 250 kwacha, then you will have under your outpatient a 10,000 kwacha that you can use to access your medical services. Then under inpatient, you're going to have 25,000 kwacha. Then under optical, you have 3,000 kwacha. Dental, you have 3,000 kwacha. So on the gold plan, you pay 350. Then you will have access to 15,000 kwacha for your outpatient services. And then you have 35,000 kwacha for inpatient, optical 3,500, and then dental 4,000. So for gold comprehensive, which is a bigger plan, averagely bigger plan, we have 500 kwacha that you can contribute on a monthly basis. And then this 500 kwacha will be able to give you a 20,000 kwacha on your outpatient, 50,000 kwacha on your inpatient, and then a 4,000 kwacha for dental, for optical, and then 5,000 kwacha for dental. And then the last plan we have, you contribute a 750 kwacha on a monthly basis, then you will have access to 25,000 kwacha, and then inpatient you have access to 70,000 kwacha, optical you have 5,000 kwacha, and then dental you have 7,000 kwacha. So these are the plans that we have so far put together. And for those of you that wish to register, like I mentioned, you can register with ourselves outside there. There's actually also a link that has been provided. If you want to register online, you can register through that link, and then we'll be able to get in touch with you. I'm sure the contribution way has already been communicated to you, the means that you can be able to contribute. Just to mention also on these plans, these are per individual. So if you have family members, it means each of the people that you are putting on the scheme, you would have to pay 250 if you are choosing silver. So per person you're adding, you need to contribute that amount. So we are simply putting together all the funds that you are going to be paying to assist also the caregiver to receive care when it is time for them to receive. Unless there are questions, this marks the end of our presentation.
Thank you very much. We are trying to rush for time. And so we will go into the next presentation. Madison is here. You have a booth outside, isn't it? Yes. So you can go and talk to them. You can actually see from their calculations that they are actually wrong. I hope you have seen that. If you are a family of 5, paying $250 each a month, in a year, how much are you going to pay? And that is not insurance. That is investing. All right, Mr. Mwamba or Dr. Mwamba? You can only say that after they have paid you the money. Otherwise, you say that before, they won't give you any money. You are doing everything. I'm introducing my team. Oh, good. Thank you very much. So, Prof. Wilbrod Mutale will introduce the team that is going to make the next 3 presentations. So we'll have all the 3 going, then question and answer. Prof.
The name has changed, Wilbrod, from Nancy. So Nancy, very good work that you are doing. We are going to present some work we are doing with CIDAS and the University of Zambia where I work. And this work is called, in short, TaskPen. So really we are trying to focus on how do we address the double burden of NCDs, of diseases that we see in people with HIV. So we've got people who have been on ART for a long time, and now what has happened, some of them are developing hypertension, diabetes, and dyslipidemia. And so we wanted to do some intervention that does not include the doctors, because we know we have got fewer doctors. And so we did get some funding, about $3.7 million from the NIH, to do this work with CIDAS and UNZA and UNC. And here now, we did what we call a pilot. So this was a phased study. Part of the phase 1 is basically to have pilot sites and test the intervention. And that's the result that we have today to show you, is it feasible for non-physician health workers to actually attend to NCDs? What are the processes? What should you think through? And then we also have got few results about the distribution of hypertension in this group and some of the things that really pertain to the risk factors. So hopefully you can enjoy this, but also next year, hopefully we can bring now the larger clinical trial which is underway. So with me, Dr. Mwamba is going to start, and then Dr. Taylor is going to follow, and then we are going to have blessing. Maybe the order might change a bit, but otherwise we are good to start. Thank you very much.
Good afternoon, everyone. My name is Mamla Telo Siame Mumba, but most of you know me as Telo, which is the last 4 letters of my name, very short and sweet. The problem with having a professor speak before you is that he says everything, so I can just say, thank you very much, we are done. Nonetheless, here we are. So I am presenting this work that was done by the team. So it's a mixed methods formative research and pilot testing of a task-shifted adaptation of the WHO PEN intervention to address the cardiometabolic complications of people living with HIV in Zambia, and in short, as has been mentioned, TaskPen. And this work, as Professor has mentioned, is really an embodiment of what we can call mentorship and collaboration. As I go through the process presentation, or the process that we undertook during this phase and some of the results that will be highlighted, and I must mention that these are just really a snapshot of some of the information that we've been able to get so far, and more will be coming. When I talk about mentorship, I'm speaking about how the professor has mentored most of us in here, and or the presenters rather, right from me, a middle level, and all the way down to the most junior of us who will be also presenting here. So we also do thank him and the team for this opportunity to present all this work. As has been mentioned, this is an NIH-funded grant, and the multiple principal investigators are Professor Wilbrod and Dr. Michael Ethe, and there are many co-investigators on the team who we did not manage to put, but even to my left, Professor Faston is also one of them, and I will mention some of the work that he has also been influential in terms of this research. And the TASPEN Zambia is part of a consortium of 6 countries within Africa. That's South Africa, Botswana, Nigeria, Uganda, and Mozambique, looking at cardiometabolic complications in persons living with HIV. And I think ours is really the most complex of all and the most interesting of all. So what are some of the gaps that we hope to address in this process and in this implementation? So the problem of cardiometabolic conditions or non-communicable diseases has been noticed, especially amongst HIV clients, to be quite increased. And of course, this is due to some of the interactions with the HIV itself, the drugs that our clients are on, and also systemic inflammation and other factors that have been noticed. Secondly, it's also, there's a commonality to the management of non-communicable diseases. It is a chronic condition, similar with HIV, so how do we best integrate these systems to ensure that the management of our clients living with HIV is optimized? And then thirdly, as has been mentioned, in the realm of HIV, there has been a lot of task shifting in terms of the care from the doctors to the non-physician healthcare workers. So how can we then use the same system in the management of cardiometabolic conditions to ensure that we improve the outcome, as many of our clients are living much longer now, but are having morbidity and mortality from cardiometabolic conditions. So what is this WHO pen that we speak of? So this is a package that was established for low and middle income countries in terms of the management of non-communicable diseases, but this has not been tested in the realm of HIV and how this can be integrated. So this is where our research did stem from, and this is the question that we did seek to answer. Is it feasible, acceptable, and appropriate to task shift the delivery of an evidence-based package of integrated cardiometabolic health services for persons living with HIV within Zambia's national HIV program? So this is a question we attempted to answer in this pilot phase, and then, as has been mentioned, it is phased and has been upgraded already to the larger trial. But in this phase, this is what we're trying to answer. Can we develop this package? Can we then pilot it and learn lessons from it so that we can then upscale it for us to get more lessons? So it is a mixed methods approach, in which we call a mini quasi-experimental trial. And really our overall aim, as has been mentioned, was how do we adapt, pilot test this tool for a task-shifted, locally informed intervention for the screening and management of cardiometabolic metabolic conditions. And the two aspects were adapting and also pilot testing. So what is this package that we speak about when we talk about the TASPEN? So it has the 5 components, which is the adaptation of the protocols and the training materials from in the national context, and this is mainly from the WHO pen, but also how do we then strengthen diagnostic capacities for decentralized monitoring, things like HbA1c, lipid profile. So this is where we have a point of care system that can then be used in our primary healthcare facilities to help manage the NCDs. And then looking at our HIV care, which is largely centered on an electronic management system, how do we infuse some of these lessons, or how do we adapt it so that it's easier for the non-physician healthcare workers to use? So we then adapted the smart care and infused some aspects of non-communicable diseases care in the program, so that even as, whether it's a registry clerk, whether it's a clinical officer, there are certain points that will help them in terms of the management of NCDs. And then also leveraging the HIV infrastructure and systems, so around logistics to really strengthen this, and finally the task shifting and the task sharing of responsibilities right from the screening and onto the management as well. So in the adaptation and the formative stage, we did use a qualitative component where we did speak to individuals right at the facilities. We also spoke to key stakeholders in key positions at the Ministry of Health and ZAMSA and so on, to try and gauge what this might look like and really use some of this information as we develop the tool and the package. And some of the findings right from the right from the facilities, as some of the healthcare workers felt there were no protocols to help them in terms of the management of non-communicable diseases, and they actually also felt that this would benefit most of their clients if they were able to have everything under one roof. And even from the healthcare worker side, that we had some who actually said this would be good to have protocols, but others were saying we do know what to do when this really just make it like others won't be able to use it and so on. So we're able to use some of these, and then once we had the intervention, also continue to learn some of these from this. So this is basically a picture of what exactly we did. So on your right-hand side at the bottom are the guidelines and that were developed. On the top right-hand side is the AMR and the task shifting on the left, and the use of the community and the point of care testing as well. So in the second aim, we were then piloting this intervention, and the two speakers that will follow me will speak to how some of the results we got from this will be some of the lessons that we learned as well. So we did launch the intervention. So when we said launch the intervention, this was available to all persons that were accessing care in the clinics. So this is 2 clinics that we use. So we use a mini step wage study. So George and Chilenge were the facilities that we piloted this intervention. And when I say step wage, we did start with intervention in one facility with George, and 3 months later we then stepped up and did do the intervention in the other facility, which was Chilenge. And in that period that George was under the intervention, Chilenge was a control, and then we're able to learn lessons through the cross-sectional study that we're able to do. And then we had a nested cohort in which we're able to now gain a bit more understanding of this, though we'll not be able to present some of those findings from the cohort just yet, but we're able to also follow through a select number of clients through the period and do other tests and also other surveys and questionnaires. Additionally, again, the qualitative component in terms of the interviews and structured observations were also conducted before we did the intervention and also afterwards, so that we can have a more comprehensive understanding of what this integration does look like and what it will mean for the future, and lessons that can be learned for the actual scale of this to all facilities within Lusaka and the country. And we did have some challenges, and these were actually then used to help us in terms of the larger trial, which has actually started in terms of, there was a lot of issues we found around the attitudes and behaviors regarding the guidelines and the use of it. So how did we then, we use some of this information towards what is being done now as we have upscaled. Then there was also other lessons that were learned in terms of the commodities, and we all know that a lot of the patients, once you come to the facility, you want drugs. If there are no drugs, they feel like you've not been helped. So we did also have to find ways of ensuring that that was also improved as well. So there are a number of lessons, number of things that we have learned from this, and we hope that next year we'll be able to present more details, both from the pilot but also the actual scaled-up intervention as we go along. So we'll now have the other 2 presenters that will give some of the findings that we found from the pilot. And also just to make mention that this work would not have been possible if it wasn't for a huge team that are in here, Professor Goma, Dr. Mlaya, Muvambe over there, and many others that, Professor Walika as well. They all came in to really contribute to the formative stage in terms of the guidelines and that were done, and also intervention, and we continue to rely on some of the knowledge and some of their expertise throughout the study as we did continue to have consultative meetings and so on. So thank you very much. Dr. Mamba, over to you.
Good afternoon. So just in case you couldn't keep track with the fast English from Taylor, I'll try to be much slower and make sure that I cover everything. Can I have the slide, please? So as we're waiting for the slides, so before starting the task-based study, we did a baseline site assessment and survey just to understand what could be the actual burden of these NCDs. Of course, we touched to hypertension, diabetes, and dyslipidemia, but the result that I'll present today will focus mainly on hypertension. Yeah, Telo forgot to show the beautiful team that is behind all this work that you are seeing, that the task pen study. So we couldn't name everyone, but yeah, we've managed to capture the bigger group there. Okay, so I'm Daniel Mwamba, I work for CIDAS. Currently I serve as a senior technical advisor under the USAID Zambia Integrated Health Project. We know that we've done a lot of progress in ensuring that people living with HIV live longer, but as a consequence, you know, they're exposed to non-communicable diseases that comes with age. But not only age, we've mentioned the effect of the virus itself, but also the drugs that they are being subjected to. There's quite a lot of work that has been done around NCDs and HIV, but we still have a lot of gray areas or a lot of gaps in research. Things to do with what could be the contributing factor of bacterial translocation in development of cancer or NCDs. Lately, we've been talking about weight gain and dolutegravir. We still have quite a lot of things to learn about it. Dyslipidemia for those who are receiving protease inhibitors or TDF-induced kidney disorders. So when you look at the global trend of mortality, I want you to focus on the low-income country where we belong to. And this is a projection like between 2015 to 2030. The color in black down there represent infectious diseases, HIV, TB. And you can agree with me that we are doing fine in reducing mortality related to infectious disease. But when you focus on the blue area, cardiovascular diseases, mortality due to those conditions are actually increasing. So as much as we are maintaining people in good health with ARVs, but we are not doing fine in preventing death due to cardiovascular disease. I also pull out this finding. This was published this year. It's a finding from a cross-sectional study that was done in Zambia. So this study looked at data that was entered in SmartCare and look at how many of these patients that we have in SmartCare actually have blood pressure recorded. They look at over 750,000 patients, age above 18, and they picked 2 visits. So only about 13% of these patients had actually BP recorded in SmartCare. And from those that had BP recorded in SmartCare, 14% have had high blood pressure. And from those who had high blood pressure, only 8%, 8.9 exactly, were receiving BP medications. So this tells us quite a lot of gaps that we need to address. So you can agree with me that data on NCD's prevalence in Zambia among people living with HIV is scanty. And factors like knowledge gap from the providers, healthcare providers, could contribute to this. We also don't have, updated protocols, standard operating procedure for some of these conditions. The supply chain is also a problem. Not only the drugs, but even the BP machine, the scales, the glucometers are not always available in public institutions. And we strongly feel that understanding the burden of NCDs among people living with HIV, but also the barriers to care access is key for us to provide better screening and management of these patients. That's where now the task pen study comes in. I will not go into details of this. It was covered by Professor Woodward as well as Telo. Yeah, so as I mentioned, we did a pre-study baseline survey. We designed a questionnaire that we administered in the 2 pilot sites, Chilenge Level 1 Hospital as well as George Health Center in Lusaka. This happened between March and April 2022, just to ascertain the burden of hypertension among people living with HIV. Here I will just present hypertension and its comorbidity. The next presenter will tackle the other comorbidity related. So we recruited some participants. I'll share the number. And the questionnaire was administered. Data was entered in Excel, and data was used to analyze. We only focus on people living with HIV on ART, age above 18. We excluded pregnant and breastfeeding women. For BP measurement, we used the WHO classification, and the normal BP was considered at any systolic blood pressure below 130, combined with a diastolic below 85. We made sure that the patient was, seated with feet on the floor, resting well. We took 3 measurements within 5 minutes, and we recorded the mean blood pressure of the 3 measurements. Study participant demographic as followed. We had 332 female and 115 male. Majority of our participants were aged between 55 and 49. The male were slightly older than the female. We looked at their educational attainment. Just about 55% of female completed primary school, and for the male, 40% went up to having a secondary school certificate. Very few of our participants had a postgraduate certificate. We looked at their marital status as well. Interestingly, majority of men are actually married, 65%, against 37% of women being married. And when you look at the widows, you have up to 30% of women being widowed against just 7% of men. This could, I presume that men always get married again once they lose their partner, while the women will stick to remain faithful to the dead person. So then we look at their ART regimen. As expected, majority on dolutegravir-based regimen, more than 90%. At this time, we're still going to transitioning to the most efficient DTG-based regimen, and that's why we see some few patients receiving a efavirenz-based regimen. We look at ways to hip ratio just to try and understand do with truncular obesity and fat deposition around the abdomen. We didn't see much because it's all below 1 for men and below 0.9 for the female. Men were found to be taller and lighter in terms of weight, while we have women who were shorter and heavier. And we looked at their body mass index. 32% of women were obese against only 3% of men. And 17% of men were actually underweight against only 4% of women. So you can't be underweight if you're the one cooking. So that's why we... So for blood pressure, here we're looking at mainly the systolic. I'll just run to the crude prevalence. For female, we stand at 23%, and for male at 35%. And when we classify these by hypertension category, majority of actually female have normal blood pressure, 42%. We had close to 40% of men having high normal blood pressure. Grade 2 hypertension compared to women. So when we adjust for gender, age category, smoking status, BMI, therapy regimen, years since diagnosis, and how many years they've been taking medication, we found that 36% of people living with HIV actually have high blood pressure, taking into account both systolic and diastolic. I wanted to show you this interesting slide. The line in red there, it shows when we started the intervention as taskpen. And you can see in blue the number of ART visits that we had at Chilenge. In orange, you have BP record. So you can see that before the intervention, there was no BP record entered in Smart Care at all. Then after the intervention, the orange line are actually getting closer to to meet. This was a picture from Chilenge, similar trend at George Clinic as well. So in conclusion, a total of 447 participants were recruited, 72 or 74% were female. The crude prevalence of hypertension was found to be at 33% at Chilenge and 39% at George Clinic. This shows high prevalence of blood pressure in high blood pressure in Lusaka. Obesity was found to be more prevalent in women. And this justifies the need to strengthen NCD screening, prevention, early identification, and appropriate management if we want to improve health outcome of our patients. Thank you so much.
Good afternoon, everyone. Good afternoon, everyone. I'm extremely excited to be here. My name is Dr. Blessings Kasenge, and I'm a clinical research mentor on the TaskPen project at the Center for Infectious Disease and Research in Zambia. And I'm extremely excited also because my mentors gave me an opportunity to be able to make this presentation, thanking Professor Wobrod, Dr. Telo, Dr. Mwamba, and of course many of my teachers who I can see here from UNZA, Dr. Maplanga. I saw Dr. Mtaja, Dr. Jen Kabwe. So thank you so much, and I'm extremely excited. So we looked at the prevalence of tobacco smoking as well as alcohol consumption and their relation to hypertension in adults living with HIV at George Clinic as well as Chilenge First Level Hospital. And this is just an outline of my presentation. So according to the World Health Organization, non-communicable diseases, particularly cardiovascular diseases, will be the leading cause of death by 2030 globally. And tobacco smoking as well as alcohol consumption have been associated with an increased risk of cardiovascular diseases, particularly hypertension. So people living with HIV on ART are at increased risk of developing hypertension and its complications compared to the general population. Therefore, tobacco use and alcohol consumption are major risk factors for developing hypertension, and it is a leading cause of cardiovascular as well as cerebrovascular mortality in people living with HIV. And various studies have been done. For example, a study was done in Nepal where they established a high prevalence of tobacco use as well as alcohol consumption and hypertension in people living with HIV compared to the general population. Another study done in India showed that there was a relationship between tobacco use, alcohol consumption, and non-communicable diseases, and this was done in women. Another study also done in Spain showed that there's a higher prevalence of tobacco use among people living with HIV than the general population. And therefore, our study basically was seeking to establish the prevalence of tobacco smoking as well as alcohol consumption and whether they're related to hypertension or not in people living with HIV in the two healthcare facilities that I had mentioned. So globally, when you look at the HIV prevalence itself, 67% of people living with HIV reside in sub-Saharan Africa, and 1 in 3 individuals living with HIV in sub-Saharan Africa have hypertension. And when you look at the prevalence of tobacco itself in Zambia, we have a prevalence of 11%, and this has been increasing when you compare it to the previous surveys that have been done on tobacco. There have also been inconsistent highlighted associations between tobacco use, alcohol consumption, and hypertension. However, what has been established is that the combination of drinking and smoking has been associated with a higher mortality. So the materials and the methods were mostly what was presented by the precurrent speaker. And so the results from our findings then were that 4.92%, which represented 22 of our participants, were current smokers, and 64 or 14.32% were former smokers, with 361 people or participants saying they had never smoked. And of those of our participants, 44.74% consumed alcohol, and 247 participants, representing 55.26%, had never consumed alcohol. So the precurrent speaker did give us statistics on the hypertension, and I'll skip this part. Yeah, so just a summary of the demographics. So we see that the mean age of our participants, the female participants, was about 45, as well as in men it was about 46, and most of our participants were aged between 45 and 59. That's for both female as well as male. So coming to the tobacco itself, of the female participants, 1.51% were current smokers, and this is in comparison to the men, where 14.78% were current smokers. And you also note that over 92% of the women had said they had never smoked, but at least 50%, which is 47.83%, said they had smoked in their lives. And this is basically also a summary of the alcohol consumption. So you notice that at least 60% of the women said they had never taken alcohol, and this is in comparison to men who 60% had consumed alcohol at some point in their lives. And down the table, you'll be able to see just how we assessed in terms of the number of drinks that each of them was consuming. And you'll notice also that when it comes to the number of standard drinks, we realize that men consumed more standard drinks, 6 or more standard drinks weekly compared to women. And so when we come to the odds ratio, you realize that there's an odds ratio of 2.1%. That's 2.1% odds ratio of having hypertension from smoking. And then we also had a 2.74% of having hypertension from tobacco smoking, though it was just missed out on this slide. So then what do we establish from our study? So we established that the prevalence of tobacco smoking was 4.92%, and this was lower than the prevalence of 14.4% as reported by World Bank data. And this is particularly because in our study, we only captured tobacco smoking. We did not capture things like smokeless tobacco, which would also contribute to developing hypertension. You will notice also the prevalence of hypertension among people living with HIV was at 23.4% among female and 35.7% among male, and this was already established by my previous speaker. And you notice that the prevalence was higher in Nigeria, was higher compared to other places like Nigeria, as well as Uganda. However, it was lower when compared to Malaysia. So when you come to the alcohol consumption itself, the prevalence of alcohol consumption was 44.74%, and this is significantly higher than the general population, according to a study that was done in Lusaka, where they established that according to the general population, at least 26.3% were consuming alcohol. So we see that the alcohol consumption was higher among people living with HIV when compared with the general population. And then also you see that the odds of developing hypertension from alcohol consumption was almost double, as well as the odds of developing hypertension from tobacco smoking was almost double. However, we do establish also that the higher odds of developing hypertension from tobacco smoking when compared to alcohol consumption. So in conclusion, as I have earlier stated, there was significantly high alcohol consumption prevalence when you compare it to smoking, and of course the odds of developing hypertension when you compare it to when you compare alcohol as well as tobacco, you realize that there's more chance of you developing hypertension from tobacco smoking as compared to alcohol. And therefore, what are we saying is that there's need to intervene by offering support, enhancing health education, as well as providing better HIV control, because we have seen that people living with HIV are predisposed to these risk factors. Thank you so much, and here ends my presentation.
Thank you. Thank you very much. We will have a short question and answer session. And so, please, we will be looking for questions rather than commentaries, because we still have 2 presentations we have to squeeze onto that agenda. We will have a short presentation on injuries from Dr. Bright Moyo, and another short presentation on mental health from our short man, Naeem Dalal.
Good afternoon. My name is Nancy Kasongo. I wanted to find out from the team whether there was any consideration for white coat hypertension. Was there any intervention taken to maybe prescribe ambulatory blood pressure monitoring? Because, yeah, I think that's enough.
Thank you very much.
Yes.
Right, next, our lady, and then the 2 gentlemen. Oh, there's another hand behind. Okay. So we'll go that way, then we'll come back to Dr. Starley. Thank you.
Okay, thank you very much. My name is Carol Milambo Mfana from UK Health Security Agency, and mine is related to the immediate previous presentation, comparing the prevalence of hypertension in Zambia and other countries such as Nigeria and Uganda. I've heard anecdotally people talk about how much salt we consume as a country and how salty our diet is. So I was wondering whether there is, when you're looking at the statistics for the other countries, was there any dietary aspect to it? Did salt come up as an issue as well? Thank you very much.
Thank you. Yeah, so Dr. Stali, but there are our two colleagues outside. Yes, so you may go. Yes, please.
Hello. Good afternoon, I'm Jonathan. I have a question for the second presenter. I think first my comment would be, I think you're finding that there was almost zero measure of hypertension or BP prior to your intervention, I think is worrying. I'm wondering then that isn't your finding suggestive that that is what is obtaining in the country? The fact that you have so much hypertension undiagnosed, isn't that a reflection really of what is obtaining in the country as opposed to it being specific to people living with HIV and AIDS? To the last presenter, I was looking forward to looking at your methodology. I noted you glossed over that particular aspect. You did give us prevalences of your hypertension in people living with HIV and AIDS in the two sites that you did the study. My worry is you didn't compare it to the general population. How does that finding compare to general population here as opposed to the places where you indicated?
Thank you very much.
Good afternoon, Dr. Hachizo from TDRC. I just wanted to find out, when you're looking at aspects of smoking, did you only consider tobacco smoking, or you also looked at the use of tobacco, like the way women put it under the tongue, and also those who sniff it? Thank you.
Thank you very much. Dr. Elpilias Chiwaya from ZMPHI. I think my question is in line with what Madam has just asked earlier. If the research or the study had put in consideration the salt intake in our country. Thank you.
Thank you very much. Shall we have the responses? All right, so please come. Then the others can get a mic, but I think you need to all come and answer from here. At least someone can lose a kilo of some little exercise.
Really?
Not the speaker, but one of the speakers.
All right, I think we are fine here, Prof. We'll share this mic. All right, so thank you for those questions. And I think in my preamble, I did mention that there's some information that obviously we are not able to give at this moment. So in terms of the consideration for the white coat hypertension, Nancy, when we talk about the task shifting, some of the blood pressure measurements were actually done by the peers and volunteers. Of course, there's the issue of environmental aspect to that, and that's why 3 blood pressure readings were actually taken during the study. And I might also add that that thought did come through, and some of the things we've been talking about in terms of where does the study go from here is looking into how we can actually do blood pressure readings in the community. So that's something we're looking forward to develop, and maybe that can actually counter that. Then looking at the salt aspect. So one of the tools that we use in terms of our methods in terms of the data collection was the WHO call. So I did mention that we did have a cohort that at this point were not yet able to give some of those results. We're still looking through them. So one of the aspects that did come out in that survey or in that questionnaire was the aspect of salt. And at this point, I also talk about the tobacco. We did look at tobacco smoking only. We didn't look at the other aspects of tobacco use, which was quite interesting because it's something that came up when we're training the non-physician healthcare workers to saying there are all these things, how can we put them into place? And of course, this does leave a lot of gaps and avenues for us to look at other areas of research that we can actually go into. What was the other question? Was there any other question for me? Okay, I think there was a question on the methodology in terms of for Blessings. Do you want to answer that, or I can go ahead? Okay. So for the methodology, I think maybe we were a bit too fast, Dr. Stali. When we talked about we used the survey. So that the cross-sectional survey did ask the questions about whether they smoke, whether they don't smoke. So it was very quantitative in that aspect. Of course, there's more information that I mentioned that we can get, and we hope that we will be able to give that information in future scientific conferences. Daniel, Blessings?
Thank you. I'll answer the question on data entry in smart care for blood pressure. Yeah, so the picture I presented here looked at a period from January to May, because our intervention started in May. So that's the picture we found for that particular period. But when you compare it with what I presented from the cross-sectional analysis that was done nationwide, where we only found 13% of patients living with HIV having a blood pressure recorded in smart care. So it's not very different. It's possible that during the period that we conducted our baseline survey, maybe the BP machine wasn't working, possible from January to May. But there's also the fact that in most of these ART clinics, when you go there, the BP is checked by, most of the time we task shift this row to non-professional healthcare workers. So they'll write it on a small paper at triage, and at triage usually there is no smart care there, so they won't enter it. They'll give you that small paper, you go with it to the clinician, and it's the clinician's responsibility to enter it in smart care. So blood pressure is probably measured, but not recorded in smart care. But then again, we have a situation where the machine is not there or the machine is not working. And we've seen situations where you have only one BP machine for the whole health facility, and it keeps moving from MCA to ART to inpatient to ICU and everything. So that could also explain that. So what is not documented wasn't done. So, but that's what we found, both at Challenge as well as George Health Center. Thank you.
All right, thank you so much. I think there were two questions. The first one was talking about comparing the prevalence of hypertension in HIV compared to the general population. So there is a STEP survey that was done. I think it was an oversight on our part that we did not show those comparisons. However, we can make that STEP survey available to everyone in the audience. And then there was also a question on tobacco. So currently, what we're doing right now, we've managed to capture smokeless tobacco, because tobacco is wide. There's smokeless tobacco and those other types of tobacco. But in the pilot, we mostly focused on tobacco smoking. However, right now, we're focusing on other tobacco products. And we've even gone further to also develop a tool that can help in terms of those that are addicted to tobacco smoking in our current study. Because what we don't want is where we're just treating, for example, hypertension, and we pay a blind eye to other risk factors, for example, tobacco itself. Well, thank you so much.
Thank you very much. A big hand to our colleagues. A lot of information coming in from the hypertension and tobacco front. I hope you look forward to the CPHI conference coming up late November. What you have seen here is mostly from PEN. At the CPHI, you will have some data from PEN Plus. And it's really an overlap of the two, but a build-up. And PEN Plus goes more clinical, and so we hope you will be there for that conference, then you can hear more. The issue about smokeless tobacco, I think, is serious. We had some focus group discussions in Mongu with tobacco users. 8 men, all of them smokers. 8 women, none of them smokers. All of them were using Sunko. So I think there's a lot of data which is missing when you just talk of smokers. Dr. Bright Moyo, can we hear about injuries? So just a little patience. I know that gastric motility has increased, but I can assure you that the large intestines won't swallow the small ones.
Thank you very much. Just a disclaimer. This is not a scientific paper presentation per se. It's just a literature review. and with some clinical insights. Expert evidence, if you like, level 5, just to shed light on the evolving nature of injuries. So those are my names, Bright Moyo. I'm an orthopedic surgeon at the University Teaching Hospital. Can move to the next slide? So that's just a brief overview. We'll talk about the burden of injuries, new threats, evolving interventions, and some recommendations. Oh, okay. All right, I've been guided. I'm able to move the slides. So this is just a literature review of one of the papers that we're looking at. You know that 4.3 million deaths occur globally due to injuries. And the low and middle income countries take up a burden of this, a big burden of this. When we narrow down to Zambia, we know that it has got a high rate of mortality and morbidity arising from injuries, particularly road crashes. I think this is the scenario in most African countries. And the paper that we looked at put the deaths, injuries, deaths arising from these injuries at 46 per 1,000 population, which highlights the burden that it takes on our public health system. And of note is that the main causes are falls, exposure to mechanical forces, and animal contact, especially in the rural areas. We get a lot of hippo bites, crocodile bites, and these sorts of etiology. Now, I think this was the focus of my presentation. Just wanted to highlight the evolving landscape of injuries. So we do know that the roads are getting busier, people are getting more innovative. So we know, for example, like Eastern Province, we used to have a lot of motorcycles, but that has changed now. It's across the country. When you look at Lusaka, so many people ferrying packages on motorcycles, we all use them. If you look at the border towns, so many motorcycles as well, and some of them are ferrying people illegally, being impounded by RATSA. So we've got all these motorcycles that are now on our roads, but our policies have not caught up. So you look at countries like that have done well, like the East Africa, the Rwanda, Uganda, with the borders, that is coming to Zambia now. So we're seeing a lot of these injuries arising from motorcycle crashes. So I think that is one of the emerging threats to our landscape of injuries. We also know that I think the geologists have been doing, they've been working in overdrive, because suddenly there's minerals here, there being announced. And with that comes a lot of challenges. So one thing that is happening again is that we're getting a lot of injuries from illegal mining activities. This tends to be polytrauma patients, a lot of them due to load falling on them or earth movement, landslide and things like that. So they tend to be quite polytraumatized patients that need multidisciplinary care. And those are the ones that make it, but a lot more obviously don't. In Lusaka and the Copper Belt, we're also getting a lot of blunt trauma arising from group criminal activities, what has been termed junkies now. So especially from the high populous communities, almost every day in casualty, we're seeing a lot of these cases. I was attacked by junkies. I was attacked by junkies. And obviously, we cannot emphasize interpersonal violence. We read the news. This remains a big, big concern, as well as self-harm. I'm sure Dr. Naim will talk more about this. But these are some of the challenges that we're seeing. Non-traditional causes of trauma now adding a burden to our public health system. So what are the evolving interventions? So obviously, there is no substitute for a good public health system that's able to respond to emergencies. We have done well, but not well enough in terms of human resource. We're now training cadres that provide emergency health care services on site. Obviously, the numbers are still far, far, far from what they need to be, but it's a start. There's a training program at Chainama, but obviously we're still lacking in terms of transportation and the equipment, and those cadres need to be supported. So in the meantime, it's sort of, our system is based on a good Samaritan kind of approach. So if the trauma happens, mostly the first responders are fellow road users or pedestrians. And so we've seen a need for really to integrate this primary health emergency response, primary care at community level, these first aid trainings. But all this needs a multi-sectoral approach, because when you have trauma, you have different departments from different ministries responding. You have the police coming on the scene, you have RATSA coming on the scene, you have local government when people are trapped coming on the scene, but there seems to be no coordination. Who is coordinating this emergency response? I mean, it's there, obviously, but what we mean is where you have decentralized teams, and that work with policies that are based on evidence. So at the moment, sometimes you find maybe the senior-most government official that's there becomes the one that's coordinating the response and things like that. But I think we have a role as clinicians, even in preventive care. And I think that's the message we've been trying to spread across. For example, the security arm, you've seen the security wing, you've seen C5 when they are attending to a response. They'll be on windows with guns and all that. One mishap, and they end up at casualty. So we can have a conversation, for example, with Ministry of Home Affairs to say, how can we improve safety? This is not safe, riding on windows like this. So we have a role even in prevention as clinicians. And I think we need to bring everyone on board so that we have a coordinated multi-sectoral response that's based on evidence and data. Obviously, safe transportation remains a big, big issue. A number of these injuries are exacerbated by the first responders because they are not medical personnel, and then secondary injuries are caused and sometimes even fatal accidents. Obviously, the story of establishing level 4 centers, in particular trauma centers, has been discussed for a while. Looked at the busy corridors. There was talk of establishing at least 4 for a start. I think that's work that's in progress, but I think there is need. But even with the trauma centers, there's still no substitute of multidisciplinary care. I've just seen my boss walk in, Dr. Schizia. A lot of these patients that we treat, it's multidisciplinary. I find there's head injury, there's injury to the extremities. So in a patient maybe who's diabetic and it's poorly controlled. So if you have a trauma center, it still doesn't mean you should substitute multidisciplinary care. I think that's something that was the global medical community was going towards, but now we are reversing so that we have a highly specialized center within amongst other centers, like we've done at UTH, where you've got CDH, you've got Children's Hospital, Women, all those are level 4 centers, but within a set of centers, so that we are still able to rely on each other. So I think it's a call that we realize these trauma centers, but not to forget multidisciplinary care. Obviously, multi-sectoral approach remains something that we continue to call for on the trauma side, because really we need better coordination of all the stakeholders involved and to decentralize that to the different and district level. Another thorny thing, particularly in my field, orthopedics, is the issue of insurance companies. You will know that we've made great strides. We now have National Health Insurance Authority, which is an act, and it has really, really helped with minimizing catastrophic expenditure. But for our great chunk of trauma victims, which is road traffic accident victims, they are not covered under NEMA. So the justification is well understood, because insuring of any vessel moving on the road is low. So if you have an insured vehicle, then they need to cover the injury and acute care. But with our colleagues, what they do, they will only come in at point of discharge. So the resuscitation has been done, the emergency treatment has been given, the definitive treatment has been given, and now the rehabilitation has started, and now you're at a point of discharge. That's when they'll say, no, now you can fill in the disability claim forms, and that's when the patient gets something. So in that acute phase, these patients tend to be very stagnated, and delayed treatment actually leads to poor outcomes in a lot of cases. And that's for those that can afford. There are a lot more that we just say, look, the window has passed. This is going to be conservative management, and they end up with preventable disabilities. So I think this is something that we really need to bring the insurance companies on board, and obviously need to enhance rehabilitation approaches, centers, and reintegration of the victims back into society and what they used to do. So just to conclude that injuries take a very high toll on the health system, and there are emerging threats that we've identified. Just to announce that at UTH now, we now have a global health research center. So it is my hope that next time I'm standing here, or any of my colleagues will actually be presenting published data. But for now, we just published anecdotal data from our experiences, just to highlight and shed light on the threats that we have, and that these need deliberate containment. I thank you very much. Thank you, Prof.
Thank you very much. Now, I think ZMA is taking a shortcut here, because I think we had a Zoom call about emergency care, and we were promised that we are going to have a little bit more time here to talk about emergency care in Zambia, and that Dr. Moyo was going to bring us a detailed report. And so what they have done is taken a shortcut. I hope that before we go, we will have a little bit more time to discuss this issue, because I think it's on the radar of ZMA, and it's something that we need to get some in-depth look and make firm recommendations going forward. All right, so 5 minutes for Naim Dalal to say something about mental health, So you are allowed to have some pressure of speech, but no flight of ideas.
All right, thank you, Professor. As Professor has rightfully said, as a very vertically challenged individual, I will just hold my mic here. So I'm wearing the hat of the Zambia National Public Health Institute. I am the mental health specialist at the Zambia National Public Health Institute, supporting on all things NCDs, injuries, and mental health. The background to this presentation is that the scientific committee for the ZMA's abstracts realized that there has been a huge gap in injuries as well as mental health. And because of that, they requested to say, can we at least have an insight and understanding of where we are with respect to mental health? So Dr. Bright Moyo came up and shared the injuries perspective, specifically orthopedics and trauma. I will be talking about progress on mental health interventions and diagnostics, the changing Zambian narrative that we are at. So many of you may be aware, if you attended last year's AGM, we talked a lot about the burden of mental health issues in the country. Today, I will be taking you through the interventions that we have as Zambia, the protocols that we as Zambia have published, and all of you need to be aware of and need to start implementing. And with the Ministry of Health and the Zambia National Public Health Institute, and including multi-sectoral support through ZMA, all of you as members can bring mental health to the forefront and service delivery. So I'll start with guiding you that ZNPHI launched its strategic direction from 2022 to 2026. And in that strategic direction, it guides on NCDs, injuries, and mental health surveillance systems. As it stands, mental health services are heavily focused at Chainama Hospital in the country. And when we talk about provincial level surveillance structures for mental health, the only mental health conditions that are very well communicated are substance use, and in particular alcohol. But that too, it's not well documented in terms of the indicators. So the strategic direction does guide on the importance of surveillance systems. There's also promoting mental health, public health awareness amongst healthcare workers, amongst all of you here, because there is a gap amongst all of us when it comes to identifying mental health versus mental ill health, and at what point to intervene. Integration in emergency preparedness and response. And this is something that we learned from COVID-19. And COVID-19 case management has actually integrated MHPS as mental health psychosocial services. And so even with the cholera outbreak that we've been experiencing this past year, we have had mental health interventions integrated in that. Supporting existing health systems. So we're talking about HIV. We're also talking about PEN Plus and NCDs. How can we integrate mental health in that? And that is also there in the strategic direction. And further, stakeholder coordination beyond health. Support through. But for mental health, there is a very poor referral system, as there is a gap in the health posts, in the clinics, as well as first level hospitals. At provincial hospitals, we have mental health units that are lacking. And in addition to that, this is why you'll find someone all the way from northern province, Kasama, directly being referred to Chainama. So there is a huge gap. Now, another point is this pyramid that clearly guides to say, when you wait for mental health services to be delivered, the expenses that go into the care of that particular individual rises. On the other hand, if you're going to integrate mental health at primary healthcare level, the service delivery model is going to be much more feasible in terms of efficiency, adaptability for the patients, as well as economic outcomes. So it is cheaper if you're going to offer mental health services at community level as opposed to tertiary level. Now we come to the protocols that we all talk about. Are there protocols in place in the country? I would like to bring to the attention of the membership, many of you may be aware, but many of us are not aware, that we do have a mental health act, a legislative act that talks about mental health. and what mental health services should be, what mental health training should be, and what mental health professionals are. So it's very key for us to understand that there is a legislation policy out there that guides us on principles of mental health in the country. Did you know that you cannot send a patient to Chainama with detention orders anymore? That has been repealed in this particular Mental Health Act. So these are things that we need to be aware of now, because we still see this happening amongst us as members. Mental health treatment guidelines, these were launched last year. So you also need to now know as members that we do have mental health protocols, in particular mental health treatment guidelines that are tailored to the Zambian landscape. And this is a collective effort from all the various specialists and professors such as Prof. Goma, who also came to the table and supported coming up with these guidelines tailored to Zambia's context. The medication that is available in our country, the personnel that is available in our country. So we have tailored mental health treatment guidelines in our country for Zambians by Zambians. We also have mental health nursing guidelines. Now this is a big one. And as a profession, as medical doctors, we often do need to realize that mental health care nursing requires mental health nurses. And so, even where we are working, whichever field we are in, there is room for mental health nurses to be placed in the HR structure, because mental health is a super specialty that cuts across the 4 major principles that we know: pediatrics, which is childcare, surgery, general adult care, as well as maternal and newborn care. So it's very key. And these mental health nursing guidelines actually guide on all these super specialties as well. Then, what we've been discussing so far, PEN+. Professor Goma has advocated and lobbied very hard, and now in primary healthcare level, through the PEN+ clinics, which are designed to strengthen outpatient care for NCDs at low-income countries like Zambia, have integrated basic mental health care screening and services. So there's basic rubrics and protocols that clinicians can follow at primary healthcare level. So there is this, and a stakeholders meeting also took place last week, where we finalized these particular protocols. So again, answering the question, are protocols there? The protocols are there for mental health now. Integration of mental health. COVID-19 case management guidelines has a whole module on mental health, because this was lessons learned during COVID-19, the importance of mental health in emergencies. In addition, for the longest of time, advanced HIV case management guidelines have specific modules for mental health as well. So, this brings us to capacity building. All these protocols are present. So, what do we do with these protocols? This is where Ministry of Health and the Zambia National Public Health Institute has lobbied for grants and loans where we are building capacity in mental health training packages at national as well as provincial level, so that we can have structured mental health units at provincial level. We can have trainings for select healthcare workers as train-of-trainers. We follow the WHO mental health care training. We provide care for care providers. Each healthcare facility needs to understand how to take care of healthcare workers as well. In addition to that, as Dr. Bright Moyo mentioned, self-harm is a big concern. Again, statistics are not there because of the taboo and the stigma that comes with self-harm. Because even when we have self-harm come in emergencies and accidents, oftentimes that is not recorded due to the stigma and stereotyping, and also relatives guiding to say we are not comfortable with you documenting that. Even on certifications, that happens due to self-harm. Often it doesn't come out clearly, because it will not clearly say that it was self-harm. It will say organ phosphate poisoning, and it will say respiratory distress and shutdown. So multi-organ failure, cardiac arrest. This is how it's going to show, reflect on the, where